left-hand corner is Canada, and then the whole of Asia is on the right side of the map here of the world.
Hello, Miss Anna. Excuse me, but are you in your screen already?
Yes, I am.
I think it's not yet arriving.
I'll just check, okay? I'll just... Okay. Wait, I'm just seeing the... see the thing that says sharing my screen, Sharif?
It's in the menu button on the left side of your screen in the upper left.
Oh.
Yes.
Can you see it now?
Yeah, I can see your screen now. Thank you.
There, I apologize for that, everyone. Oh, bad.
Yeah. Now.
Oh, no, I'm just going back at the map of the world. We've got Canada on the left-hand corner, and then Asia in the mid here on the right. Now you could see 10 provinces of Canada, and we're going to focus on Ontario, and specifically Central Ontario. We're approximately 50 kilometers north of Toronto. My organization or institution where I'm affiliated is the South Lake Regional Health Center. It's a 400-bed community hospital and focuses on regional cancer and cardiovascular as well. A little bit of a background of our healthcare system here in Canada and provincially as well as in our community, and talk a little bit about our care model just to give you strategies why we're using Telehomecare with our area, and looking at our population, the area that I work in, the geographic area specifically, and some of the challenges that we've had with high user patients here. Care system is delivered through a publicly funded healthcare system. That means that at point of use for the patient, it's mostly free, and most of the services are provided by private entities. You know, each of the provinces have their own level of healthcare. In Ontario, we have what we call the Ontario Health Insurance Plan, or OHIP. So this is a government-run health insurance plan for Ontario, which means that every Ontario resident that permanently in Ontario is entitled to access emergency and preventive medical care under OHIP free of charge. Ontario healthcare system, we have another level, which we call the Local Health Integration Network, or short, and are the health authorities responsible for regional administration of public health care services in the province of Ontario. And we have about 14 LHINs service that provide service to hospital, long-term care homes, community care access, community support services, mental health and addiction agency, and community health centers. In the different links, we have the health links. With City Health Links, they provide a coordinated and efficient, effective care to our patients. There are 69 health links in Ontario and 5 in the South Simcoe North York region. So where I'm going back to where I am now, to that little part of Central Ontario area, or the area that I work in, is basically geographically agriculturally based community, and we have about 315,000 residents. 80% of the area's population, or 55,800 residents, are 55 years and older. folder. So you can see what kind of comorbidities or conditions, health conditions that we might be fitting or were exposed to at one point. Some of these are gaps in our community. I mentioned with the age population, but the biggest challenge is the area that we cover. Accessibility to healthcare is restricted not just by the distance, by the weather in Ontario. The area that I've shown you is called the snow belt area. So we have more snow than any part of Ontario here in central Ontario. Some of the things that we were looking at when we were doing an environmental scan in terms of what strategy we need to put in place to address these gaps in terms of access and population needs, we're looking at target the high users, our healthcare system, look at emergency visits greater than 2, emergency visits per year, and looking at hospitalizations, about 3 hospitalizations in the past year, and also the length of stay in the hospital. One of the strategies that we looked at is the Telehomecare, which is becoming an enabler for our Health Links program, or the integrated care model that I've shown you in this slide. So in the Telehomecare program, just want to show you what the curriculum development is, the training, the implementation, and evaluation, which is the focus of our topic today. And working at the Telehomecare, empowering patients to better manage their chronic condition in homes and communities. And it's a way to manage chronic conditions or chronic disease that focuses on self-management and help our patients live healthier and improve quality of life. So strategic goals, Telehomecare expansion program, are also looking at Telehomecare being the mainstream channel to support our patients living with complex conditions. Also to transform our prevention chronic disease management model by bringing together existing programs and fostering a continuum of care. So we're not to our program, we're just looking at the services that are already in place and working in a coordinated effort to help our patients with complex conditions. Mentioned on the third bullet here, to foster a collaboration among all the care providers by integrating with the existing care plan. So trying to avoid the work inflation or the use of the phrasing working silos. We're trying to integrate all of these into a coordinated effort to wrap it around the patient with complex care. Our links, the integrated health link care model, as you can see, it also covers the determinants of health, mental health and cognitive challenges, and focusing on multiple complex conditions. Just to name a few, this is patient-centered care that needs a primary care physician that leads the action plan or this coordinated care for the patient. It could be a family physician or a nurse practitioner, and the referrals that would be made to specialists in terms of their mental health or other outreach programs, allied health medical specialists, and looking at other healthcare providers within the community. Look at our patient flow. As you can see here, the referral process, it can be self-referral or family physicians, nurse practitioners, or pharmacists could refer to our program from primary care setting at the next community care access centers. We do have new referrals from the hospitals, of course, and other health service providers and healthcare providers. Links, as I mentioned in the previous slides. The criteria would include 3 or more comorbidities, 3 ED visits in a year, 3 hospitalization admissions in a year, and for the telephone care criteria, which I'll focus on in the next few slides, there needs to be objective diagnosis of COPD or congestive heart failure, and we're looking at moderate to severe. And also we're looking at assessing the patients that are willing and able to learn self-management, because this is a self-management and empowering program, and need to be in a residential setting, not in a nursing home. Looking at the patient referrals that either go to HealthLinks or Telehomecare, or they could go to both. And you can see commonality between the two programs. We have about 40% that may be both in HealthLinks and Telehomecare. And going into HealthLinks quickly, we can further streamline them, whether they need mental health and addiction, go through that process mapping, or pure HealthLinks process. And with the Telehomecare program, as mentioned before, we need to have a complete diagnosis, obtain consent, and then activated, reinstate equipment. And we do initial home visits that include environmental scan as well as an educational scan. So you see, with these processes, they are often referred to a specialist if appropriate, and also we send them to or assign them to specific services and programs in the community, as well as what we have here in the South Lake Regional Health Center program and other programs that may support or affect their life in terms of the social determinants of health. Quick review of the Ontario Telemedicine Network. It is an independent, not-for-profit corporation funded by the Government of Ontario. It includes about 1,289 healthcare organizations and more than 8,000 healthcare providers. Our partners is eHealth Ontario, Canada Health InfoWave, Kuwait Clinical Mechanic, Tribal Council, and the Ontario Lung Association. Offerings here, you can see there's telemedicine, video conferencing, e-learning, consumer health, customer service, and operating e-consults. Our grand focus for today is the Telehomecare, but as well there's some for telepsychiatry, telederm, teleophthalmology, telestroke, teletrauma, teleburn, regional health, and Northern Ontario travel as well. Some care overview. Currently, we're just looking at COPD, congestive heart failure patients. We've actually recently included a comorbidity of diabetes as well. Our program, unfortunately, due to funding, it is time limited. It is time limited intervention, which averages about 6 months. No cost to the patient. It is funded by our government, Ontario, delivered by a registered healthcare provider, either a registered nurse or a registered respiratory therapist with life training in health coaching and self-management support. The home care coach works with the primary care provider, may be a family physician or a nurse practitioner as part of the circle of care. Is the main developer, the action planner, but that doesn't mean to say that we do have it means that we do collaborate with the healthcare providers within the circle of care. And the content is based on guidelines that are evidence-based and approved by a provincial clinical expert committee. Again, 4 corners of home care delivery include funding portion from InfoWay and the Ministry of Health and Long-Term Care, Government of Canada, so in alignment with their strategic plan, the Health Action Plan, and with the Ontario Telemedicine Network, whose role and responsibility includes management, project management, training, technology support, and quality framework, making sure that we do follow that mandate from ministry. As a host, we're considered the host. The South Lake Telehomecare program is at the South Lake Regional Health Center. We deliver the telehomecare service to the patient. We do patient recruitment. We have the clinicians that are trained in telehomecare. We have an administrator as well as a manager and an engagement lead. And the lead is responsible to looking at the program sustainability and make sure that we do align with the ministry mandate as well as give us the through the host organization is our incentive, of course, to continue on with our program. First, with which I mentioned briefly already, Ministry of Health, Canada Health Infoway, Local Integration Network, and of course, us as the host organization through the leadership of the Ontario Telemedicine Network. The programs, we have the telehomecare providers, the circle of care, and most importantly, patients and their role for self-management and collaboration in their circle of care. Made accountable. At the moment, we have about 4,100 plus patients that are enrolled. I mentioned earlier that we have 14 local health integration networks across the province of Ontario, and telehomecare is in currently live, and we're still looking at 3 or 4 our LINs that will be joining us shortly. On telehomecare, it is a patient-centered care model. As you can see, we have the clinician doing the health coaching, supporting the patient to gain the skills, giving them the confidence to do the self-management, and helping set the goals, SMART goals for our patients. How do we do this? Remote monitoring, patient monitoring. We have read feeds and alerts to be able to report to our patients or respond a patient, and looking at teachable moments at that point, and the circle of care engagement includes the clinician that provides the regular updates and consults as required. So, as mentioned earlier, it could be the practitioner, family physicians, helping us provide plans for these patients, and simple technology in the home, which includes a tablet, as you can see here on the arrow is. It includes a scale and a blood pressure monitor and an O2 saturation monitor. So technology at the home, and of course, with patients being taught at home how to use equipment at the initial home visit. So that help them set their personal goal, achievable goals, SMART goals, right? It needs to be specific, measurable, achievable, related to their conditions or related to what their priorities are. They set their vitals on a daily basis, Monday to Friday, and then they respond to specific questionnaires according to protocol. Back to the curriculum, to get certified for the telehomecare providers, there are foundational skills and abilities that are required to provide optimal telehomecare service. Telehomecare providers have to complete all the courses in the curriculum. It's a 3-day face-to-face and pre-training, prerequisite post-training curriculum. To receive the certification, clinicians have to complete 40 hours of training at least, and coordinators will receive about 2 days or 15.5 hours of training. Also, access to the most updated clinical guidelines and seeing best practice guidelines relevant to practice of telehomecare, and leveraging official clinical advisory committee expertise in relation to the clinical practice guidelines and telehomecare clinical procedures. picture of our the South Lake Regional Health Center here, and there's me right there, my coworker, the nurse that I'm working with. She's a cardiac nurse and focusing on cardiac, but we're cross-training to do both heart lung or COPD and heart failure. Look at the patient referral process. So we have links referrals. We have a few referrals from our HealthLink group. They're assessed for eligibility for Telehomecare, and we look at it as a team-based approach, collaboration with HealthLink and the coordinator, primary care, and specialist. How does Telehomecare assist and support HealthLink? When we were looking at a scan of the top-ranked case mix groupings at South Lake, they are the top 5%er, the top users, 5% users of our healthcare system or the emergency department, and our hospital admission is due to heart failure, respiratory failure, COPD, viral or unspecified pneumonia. The top 10% again includes the heart failure, respiratory failure, viral pneumonia, and COPD. So you could see in both top 5 and top 10% commonality, heart failure, and COPD. How the home care works? In steps 1, we get the patient enrollment from a patient referral. They're consented, equipment is installed, and a notification of enrollment to the referrer and to their primary care provider. Patient care delivery, there's definite health coaching, clinical documentation, monthly reporting, depending on what is agreed on with the primary health care provider, and then discharge assessment if they're ready to to the next level of care. Particularly, again, chronic disease self-management model for our patients with COPD. There's here at South Lake, which is unique to our in here. We do provide one home visit per patient. Daily patients telemonitoring with the weight, blood pressure, heart rate, and saturation. Coaching sessions, goals to improve self-efficacy, and length of stay, averaging about 6 months. Just to show you processes with the Telehomecare practice, the clinical process, all of the leadership. We're looking at the Registered Nursing Association organization. We have deemed the OTN has been deemed this spotlight organization with the implementation and evaluation of relevant clinical practices, collaboration with the host, incorporating the best practices in our program software, documentation, and reporting. And I mentioned about the training and the professional development curriculum. It is an ongoing professional development practice. With the care clinician supporting the patient, mentioned about the report monitoring, the remote monitoring with the alerts management, the physiological parameters, as well as health questionnaires. So these protocols are dependent on which condition that we focus on, mainly COPD, failure, or comorbidity, diabetes. So we're looking at signs and symptoms, their medication, lifestyles and behavior, and regular screening for depression, and that's done every 2 weeks. The health coaching and self-management support, self-care education, and goal setting and problem solving includes self-monitoring and management of their symptoms, early recognition of their signs and symptoms before they exacerbate is most important for us, close to the beginning of the program. So looking at action planning, early action planning or development of an action plan, and I'll show you what action plan we use in the next couple of slides. We also look at medication management. We don't do a complete medication reconciliation. We work with the pharmacist, the patient's pharmacist in this case. We look at their nutrition, and if further required or meal planning and so on, then there's a referral to either a nutritionist or a dietitian. We also look at physical activities. We refer them to the appropriate programs, look at the pulmonary and cardiac rehab programs that we promote, as well as here as clinicians in this at Salt Lake, we're also tobacco educators, so we do smoking cessation when appropriate. With depression, as I think I mentioned already, and look at anxiety, stress management, and sleep, and we do have programs here available, and looking at health promotion, vaccinations, and flu, pneumococcal vaccines as well. And then most importantly, I left it for last, is the goal setting, the action planning, and problem solving. Before I do all of this, there's the care navigation, circle of care, and they are not connected with our family physicians or our nurse practitioners, then we make sure that they are, connect them with the appropriate care provider, as well as the different community programs. There is a tablet screenshot of the daily questions that might be asked in terms of, this looks for COPD. So one of the questions that we ask here, is your sputum changed in color, amount, or thickness? Just to get an idea of what kind of questions we ask. And the patient, we have patients that never used the tablet before. As you can see, look at it now. It looks very simple, and with just a little bit of coaching, we're able to teach them how to use this tablet. Looking at this action plan, this is actually a heart failure action plan from the BC Failure Institute. You can see, look at, it follows the sign, your green, yellow, and red zone, and we go through this with our patient carefully and make sure they understand each of the different zones, when they're on the safe zone or the caution zone or the danger zone. And in this heart failure zone, we work closely with their primary care provider. Okay. NPD action plan with the Canadian Society. Similar approach. We look at the stoplight zone. We've got the green, the yellow, and the red zone. In the green zone, you feel well, you feel worse. I feel much worse. How I stay well to stay in the green zone. What happens when I do get into the yellow zone? What action do I need to take? Once when I get into the red zone, what action do I need to take? Zone, so we call the emergency line here at 911. But it looks complicated, but once you go through it with your patient, it made that they understand it thoroughly. So we're with action plan, their medication, and of course with their primary care provider, the family physicians or nurse practitioners. So care was implemented since December 2013 here at our institute at the Lake. We enrolled since from December 2013 until June 2015. We've had 250 patients in counting, and with one RT, a nurse, an administrator, one program manager, and an engagement lead. Our capacity is about 100 patients at a time. So this is a cumulative number of patients that we've enrolled so far. And at a time, we can have 100 patients because we have about 125 of equipment that we at the most. And our referral source, as I mentioned earlier, is from the hospital, South Lake Regional, the Community Care Access Center, other organizations, maybe the Ontario Home Association, our home care providers, as well as, of course, our primary care units. And a showing of our patient demographics. As you can see, we got NY 32% female, 68% male, and there's a range of age group from 40-year-olds to 90-year-olds. Our area might not be relevant to you, but it covers most of the rural as well as urban areas. Here we do some of our success stories in terms of our initial goal, decrease inpatient and emergency department utilization. You can see right at the beginning here, emergency and inpatient visits. Okay, look at that. And then during the intervention, while they were in telehome care, the middle part, and then 6 months after the intervention, you can see there is a decrease in the emergency department visit by 73% and a decrease in the hospitalization by 81%. For the most responsible diagnosis for any admissions or ER visits with CD and congestive failure, there's a definite decrease in inpatient length of stay from 0 to 6 months after the completion of the program, so a decrease of 72%. And estimated cost, which our business analyst is able to get out. Our average cost per ED visit for a patient is about $175. Average cost for inpatient or hospitalization days is about $546. Generally, this graphics, because it's easy to understand, there's been a decrease by 72% for cost in addition of emergency visits and hospitalization. There's been a decrease of $94,000, or a savings of $94,000 in that time period for 84 patients. Some opportunities that we've seen during this time with Telehomecare. It's going to be about 2 years now in November. To remember that Telehomecare, our remote monitoring, it's not a virtual ward, so we respond, but we tell our patients that, you're looking at your numbers, we teach them right away, tell them about the action plan, what to do right away. For example, if their oxygen level was below a number, we're looking at 88%, for example, what do you need to do? So not looking at this all day because we've got 100 other patients that we're taking care of, so we need to remind them that patients and families have to be willing and able to participate in the program. They can't just be receiving information, they need to actively participate. Next bullet there, end of life planning, palliative care for Telehomecare. It's not in place right now, but we're seeing the need for this. We're not tightening up the target eligibility criteria because we only have those allotted equip 100 patients, right? So we need to tighten up a little bit, but we need to have infrastructure in place before we get the being more inclusive, because right now we're inclusive. The discharge planning can be challenging, reducing their dependency. Once they cover program, they like to stay more than 6 months. So that's a thing that we're looking at as a challenge. This last thing, let's see it go.
Hello, Anna. How are you? I'm fine. How are you? I just got all those numbers and want to ask you a few questions. Do you have time for me? That's fine. Yeah. Yes. Just shoot. You haven't had any changes with your medication? As a matter of fact, she took also off some of the molecules, and yeah, it seems good. His legs are perfect. Telehomecare program is about 6 months for the patient and myself as the provider. We provide them with 3 pieces of equipment, a scale, a blood pressure monitor, and an O2 saturation monitor that's connected to a tablet so that their numbers, when they're entering it in, it automatically gets transmitted to our clinic here at the hospital. And it's specific to either congestive heart failure or chronic obstructive pulmonary disease. The home care program, it's mostly health education. The coaching is more like review the signs and symptoms, how they feel and what they're seeing. We're the one doing all the observing and answering or responding on the tablet. And also with the nutrition, diet, and activities. We been married for 66 years. We met actually because we also had a little band. I was dancing, but he was making eyes to me. We got married. We decided on a trip to Canada. Yeah, he was there. I was young and we go out and see the world. I was 90 and Ula is 85. They had some exposure with technology, but this is actually the first time they've ever had anything like this at their home. Ula's the caregiver for Otto, and you can see that they've done really well actually with this program. When we get up, what is it, Otto? That's a scale. You want to wait. Before I did any breakfast and nothing. Yeah, I count on the scale. Let's see what goes on there. The blood pressure and the oxygen. And I answer all those questions. Give all your medication. Yeah. And weight, maybe perfect today? Yeah. Now we can have breakfast. That's at the end of the program there. Listen, you can put the coffee on now. I have to do exercise every day. Yes, you have to do some exercise. And maybe you can go for a walk outside. We have a community center. We can go down there and get just walk around. And you like the shopping center better. So we can also go to the shopping center and then we run around there. A week, I reported to our doctor. And it was a great help. She was really the best thing they ever have. So you don't have to go to the doctor and sit and wait and wait and wait. Our program has demonstrated a decrease of 57% for emergency visit, as well as a 54% decrease in hospital admission. So far since we started in November 2013. It changed mostly for all. But it's a great help because you're in touch with somebody every day. At home gives me great peace of mind. It's true. Especially we need that now. If after 65, 66, wonderful years.
More information if you or someone you know could benefit from Telehomecare.
Talk about in the next few slides, quality initiatives that we're being a part of.
The goal of the Telehomecare program is essentially to empower patients
Sorry about
take
that.
control of their own health and take control of their life and have a better quality of life.
Patients have a new partner in healthcare.
That I should have stopped it. We're looking at quality framework, quality planning, and quality initiatives. And quality framework, which includes standardization of processes and pathways, interprofessional quality committee, quality ambassadors, looking at alignment with QBTs, Accreditation of Canada, ministry mandates, as well as outcomes, quality improvements, and annual review, and of course, a patient-centered care. Establishing a quality committee that meets monthly, implementing best practice guidelines, building the quality framework, implementing a quality dashboard that will develop benchmarks, looking at workflow optimization. As you see, we can only handle the only patients at this stage. Supporting quality ambassadors to for a culture of quality improvement. So, quick look at our quality dashboards, looking at patients that are key performance indicators, looking at the number of patients enrolled, number of patients monitored, total number of discharges, unplanned discharges, and so on. So that will help us look at developing better Telehomecare criteria within the area. Targeting the right patients, making it easy for our providers, and looking at our partners with the healthcare system and other related organizations. The Medicine Network its aim is to grow the home care program so that it's available across Ontario. Further improvement in our efficiency, effectiveness, and coordination of care within an environment that having active patient participation in their management of chronic disease. We want to make sure that our patients are empowered, feeling independent, while giving them the linkages or the support that they need to be able to self-manage their condition. There are areas of opportunity we've already mentioned, or we started monitoring diabetes. We're looking at mental health, palliative care, and post-acute care, chronic kidney disease, and others. And just time for. Okay.
Thank you for that very wonderful lecture and Miss Anna. We're now open for the Q&A part. So we have questions from our attendees. Okay, one. Thank you for that you started out since 2013. So we know how you started with the program and the implementation
process. In terms of engagement, is that what you're asking, Cherie?
Basically how you started with everything, with this whole program.
Oh, in terms of just the inception of it, we're looking at the top users for the emergency defined are the two top ones, the COPD and heart failure. And trying to figure out how can we help these patients, right, in terms of keeping them avoiding emergency visits, preventing emergency visits and hospitalization. So we look at how can we support them at home. So that's why we look at the home monitoring as well, and the access to the healthcare provider was restriction. Especially, you could see in this picture. I don't know if you're still seeing my monitor here. The snow.
Yes, we can still see your screen.
Yeah. So you could see that transportation or access to healthcare is limited. So how did we started the training? We looked at the skills that are required to start up the program. Since working at COPD and heart failure, so as a respiratory therapist, I focus on the COPD, and I also have a chronic disease management background. And they needed someone else that was, with specific skills in cardiac. So we have a nurse that specializes in cardiac care. She was from the intensive care unit, cardiac care unit. That's how we started. And then promoting the program is really important because even if you have this great program and nobody knows about it, you're not going to referrals, correct? We need to first work in our community, try to promote our program to the physicians and the other healthcare providers in the hospital, and then looking at the primary care settings, looking at the family physicians clinics, family health teams, or looking at the community care access centers or community health centers. So just trying to start up our program that way. We were very successful in terms of because we are in part of the hospital that we did get a number of referrals from the hospitals. So our target in the first year was 3 patients, and we managed to get that within 3 months starting the program. So we actually surpassed our target in the year and a half that we've been running.
Thank you, Ms. Anna. Here's another question. You've shared to us the funders of the program. So may I ask maybe how it is financed?
How did it's funded
Yes.
by? Okay, it's funded through the because this is a technology-driven program, funded through the Canada Health Info, who's flowing it through the Ontario Telemedicine Network, and then they have to fund that. I know this is it's like it seems like it's going in circles. So the Ontario Telemedicine Network has proposals of where needs are, where the high users. For example, the quality-based products, programs that need to be funded. So we looked at the COPD and heart failure. So it just so happened that South Lake are top 5 or 10% high users of COPD and heart failure, and it matched that mandate that the Telemedicine Network was looking for at the time when the request for proposal for new programming out. So that's been established. The funding flows through the local health integration network, and then the local health integration network is looking at the different organizations that could host the program, and it just so happened that we were already affiliated with the Ontario Telemedicine Network, that the program was flowed through the hospital.
Thank you, Ms. Anna.
Yeah.
Here's another question from Dr. Herbosa. Telehomecare operate out of a hospital base?
Yeah. Yes, it does. It operates outside of the hospital. It operates from hospital.
Another question, Ms. Anna. This program that you're using, is it only for, is there a platform technology utilized?
Yeah, right there.
I'm sorry. Is it web or mobile?
Nope, it's web-based.
Once if there's no internet connection, how proceed with the checkups, with the lectures?
Lectures with the clients, you mean, with our patients? we would do a telephone call.
So for the trainings, we would like to ask something. Facilitates the trainings that you have with the healthcare providers.
It's the Area Telemedicine Network that does the training.
Is it just for the period of 3 days?
Just of 3 days, initial training, but we do have teleconference calls often, once a month, and then that's assuming that the healthcare provider has the background already in place.
Thank you. The other question is, what are criteria for the eligibility for enrollment?
For COPD and heart failure?
Yes.
Okay, we're looking at, for heart failure, congestive heart failure, we look at the fraction, the left ventricular anastolic ejection fraction, and the Simpson percentage that we're looking at, it has to be below 55%. And the BNP, the biochemistry level that we're looking at as well, has to be greater than 300. And so we also look at their record, their medical history in terms of the cause of the congestive heart failure. Is it chronic or is it acute? And are they going for a specific procedure that will help the chronic condition, the acute condition? So that, most of our patients are myopathy is the underlying condition as well. So that's just a little bit of it, or it might be a cardiovascular condition for congestive heart failure. And for COPD, we're looking at a FE1 over FDC fraction less than 70%. And in terms of moderate to severe, we're trying to make sure that our patients are between an FEV1 greater than 30%. They are lower for FEV1 less than 30%, or less than 30%, then we refer to our Health Links program.
Miss Anna, so for another question, our Atty might have missed this part. She's asking about the referrals. So if a doctor can refer a patient to the program, can you enlighten us again on how this is done?
No problem. For referral, it could be a self-referral. It could be a physician referring to our program, practitioner, healthcare providers such as a pharmacist, RT, a nurse, community center, community health centers can refer as well. Other health service providers.
I have another question. Is phone call or consultation enough for those without internet connection?
Oh, okay, maybe I didn't mention this. And thank you for asking. Options for this program is to have internet connection. They have to have or a landline, that means a telephone line, or, which could be more costly, is a cell phone, just to have that SIM card.
Thank you. So another question, do your patients already have their doctors before enrollment?
No time. So in that case, fortunately in Ontario, we have what we call a service called Healthcare Connect. We do have online family physicians that are still, or nurse practitioners that are still taking patients into the rosters. So What it means is that, for example, if I had a patient that have a family physician or a nurse practitioner, I can go onto this website. I can go for my patient if they have internet access and type in their postal code, and then it'll give me a list of physicians that are available and they can access and are still taking new patients on.
Right. Thank you. So, I also have a question, Miss Anna. You mentioned that you have this program for the patients for about 6 months. Is it completely free of charge, include installation of the equipment, the job?
It's completely free of charge for patients. But we see as a system, healthcare system change. I know it sounds like a lot at the beginning, the cost of the equipment, the cost of monitoring, the cost of internet and connection and so on, if you add up. But it always, this is health promotion, health prevention, and diverting emergency visits and diverting the hospitalization and decreasing the length of stay if they do go into the hospital. But the most important part of it is improving the quality of life for our patient. They're not spending their time feeling sick. They know what to do. We're empowering them, giving them a chance to have control over their condition.
Thank you, Miss Anna, for your answers. Also for that wonderful lecture and sharing you've given us today. Everyone, thank you for attending our webinar. We want to remind you to check your emails for a follow-up email. So please answer our survey so we can send the materials from this session. Also invite you to join our next webinar, which will be happening on August 20. Thank you, Miss Anna. Hope we have you again in the future.
Okay, I want to visit the Philippines.
Yes, thank you. You're so welcome here.
Okay, so,
All right. Thank everyone. Good night, Anna.
good night. Good morning.
Yes, thank you.